challenges with patient motivation and kind of reaching these patients and bringing them back in, but that's the effort that is ongoing. So I'll talk a little bit about the different approaches that we have. So we do use Epic registries. Epic is, everybody here knows Epic. It's we live in Epic day to day, our electronic health record. So Epic registry for diabetes patients, these Epic registries are used, the inclusion criteria into this registry is very similar to the IHA, so that we have a overlap of the data. We have patients who have been seen within the system in the last 2 years as a part of the registry diagnosis of diabetes, and we can pull the patient data from these registries based on their A1C, blood pressure, their age, or when they were last seen by their doctor, or when they were last seen by the endocrinologist. And based on that, we can strategize an outreach sort of approach for these patients. And we also have another database which is called Ambulatory Quality Reporting System. So based on that, we generate what is called the provider attention reports, which again list the patients who are due for their A1Cs or their blood pressure or statin or their nephropathy screening. So the idea for the outreach is a holistic approach for outreach. Now our staff are, whether it's the clinical staff or the quality staff, can generate the reports at whatever detail they want, but when we call a patient, let's say, who is due for their A1C, we also, the staff will also see if they have a blood pressure which was high last time, or if they're not on a statin, or if they need an eye exam, and kind of have that conversation within the same contact, so that the patient is not called multiple times and we get one chance of kind of, bringing the patient in and motivating the patient. So we do work on a holistic approach. Now, mind you, we could involve, mammograms and colonoscopies and all that in the same visit, but, it becomes a little bit too wheeling for that conversation. So we always struggle with that. But as much as possible, we try to do our it in the same contact.
Is it just your immediate team in QI, or do you use any pharmacists? Do you use any advanced care pharmacists to help in
We
follow-up?
do. So we link up we do not use our diabetes educator or pharmacist for outreach. And the reason for that is that we have seen that, that when we did this, that we gave our pharmacists a list of high-risk patients that, hey, these are the patients who have not been controlled for a while, can you work with them? They did not have much success in bringing the patients in to see them themselves, as opposed to when the primary care physician made a referral.
Chronic care is a relationship.
Relationship.
They don't have a relationship there.
Yeah.
And that's what we learn.
So if the primary care physician said, hey, I want you to go see the pharmacist, this is the pharmacist that I'll refer you to, that made a bigger difference. And that's what we are working on, that when the patient comes and sees the primary care physician, we want to have the resources available for the primary care physician so that they can link them to the diabetes educators or the pharmacist as extended care team members.
Something that I've started to do recently in my clinic is when a patient comes and I think I'm going to get the nurses involved or something else, I introduce them to them.
Yes.
Quickly. I bring them into the room and say, this is the nurse,
Yes.
this is the pharmacist, this is, and so.
So that's a very good point what you bring, because that makes a huge difference, and that is why one concept we have of what we have talked about at PAMF, and in my clinic we have that we have our diabetes educators embedded as a part of our primary care clinic. So they are on the same geographical location as us. So if there is a patient who needs care, then I could call the diabetes educator and introduce them. Or if they come in to see me and they have a meter which is not working and they want to learn more about the meter, the educator can quickly squeeze her into the schedule, as to say. So it makes a huge difference when you have that proximity of care with the extended care team members. Now, this is one example of the physician level reports that we have, which we sort of, this is generated from the Epic registries, and this is drilled down to physician level. This is the report actually from my clinic, and we publish it, and this is put on our quality visual board, And the approach that we have with these reports is not punitive. It is not to say that, hey, you do not do this, or you know what Ed said, that we value people, but we are hard on processes. This is an opportunity to kind of see what help that physician needs, because they are primary care physicians. They have so much on their plate, competing priorities, and what resources can we give to that physician team, because it's not just the physician, it's their medical assistant, it's the receptionist, to improve their panel performance. Because it's possible that they have patients who are, they have somehow collected patients who are really high risk, who are just not coming in, they're just hard patients to deal with. So, but we do have a tracking system that we internally that we use. Now, talk a little bit on how we strategize our outreach to the patients. Obviously, we cannot outreach to every single patient. So we do use a risk stratification approach for outreach. And currently we have, it is based on hemoglobin A1C. So we start with patients whose A1C is, like less than 8, 7 to 8, greater than 8 or 9. And like 20% of our patients fall into the high risk category. So and it could change from year to year depending on what trend we are seeing in our patients. So one approach could be that, for the low risk patients, we send them a My Health Online message or a letter reminding them that, hey, you're due for your labs or you're due for your physician appointment. And for the high risk patients, we have a more sort of a proactive approach for outreach. So what we are seeing even in the high risk patients, there are two categories of patients that we can define. One are the patients who have been told everything to do. They have been prescribed the right medications and they are just not following those recommendations, or they're not picking up their medication. So those are the patients who require a strategy of motivational speaking or motivational interviewing or a motivational approach from our staff. And we have had staff training for motivational interviewing, not all the staff, but some of the staff to put resources into that and train the staff, so that when they call the patient, and if they're lucky enough to get the patient on the phone, then they can use some techniques to kind of draw the patient back in and kind of meet the patient where they are. So what they would do, for example, is that they would look into the patient chart, see what the last appointment was for and what the doctor recommended, and just start the conversation from there and see what the patient says. And the other group of patients is that they just haven't been coming in. They just have not been seen for the last 1 year, and these patients again need to be brought into our care circle. Now we've also looked at some predictive analytics, and this is where the AMG data analytics team had helped us a lot. So these are our patients who are seemingly normal, meaning that their A1Cs are 5.5 to 5.9. So you would say, okay, they're fine, let's not worry about them. But there is a group of patients which is male, obese, and if they are on insulin or a second line treatment for diabetes, their risk of what we call slipping back into out of control is really high. So we are using an approach to pay a little bit extra attention to this cohort of patients to see that they don't, that we just forget about them, okay, their A1C is fine, and then 6 months down the road, we see that they have a high A1C. So these are the patients who need more touch points, frequency of contact that we call, and that's one of the concepts that I'll talk about a little bit. So if we talk about the care delivery of our system for our patient with diabetes, as I said, it's a team-based approach. There are a lot of teams that are involved. So number one, if we look at our PAMF system as a whole, the PAMF system allows for that to happen because we have a robust leadership team who has set up the goal that, for the care of diabetes patients and communication of those goals to frontline clinics and our physicians and teams. There have been development of patient registries and reports from which we can, stratify the patients and see which are the high-risk patients who we need to outreach and bring them back into our care circle. We have looked into development of guidelines and education materials for physicians, and especially to your point about the newer diabetes medications, especially the SGLT2 and GLP-1 receptor agonists, and particularly because of the 2019 ADA guidelines which were updated and which made it really very prescriptive. Earlier the ADA guidelines were not that prescriptive on, you start metformin and then what do you do? It was kind of very vague. But this year the ADA came up with guidelines which were relatively more prescriptive on what to do with a certain category of patients. So the patients with established cardiovascular disease and heart failure, SGLT2 and GLP-1s. So we have a Sutter team which and that team is involved with development of guidelines. So we have our own Sutter insulin guidelines, we have our own type 2 diabetes guidelines. The dissemination of the guidelines is always a challenge because of our large system. Our system is so large and is so variable that becomes a challenge, and we always keep thinking of how to deliver this information to every physician. So to develop decision aid tools for let's say for example statin prescription or decision aid tools for diabetes medication. Mayo Clinic has some excellent tools which we can use, but the challenge is the dissemination because of our larger geography. But there is definitely a lot of interest and a lot of work, especially at the primary care level, because if you look at it, 90% of diabetes care happens in primary care. So if we do not empower our primary care physicians with the resources they need and the help they need to take care of these patients, we cannot keep up to the challenge.
And I think I think it's a very valid point. I mean, as cardiovascular disease providers, we cannot shy away from people with diabetes. I mean, more than 50% of our patients, if you look in the cardiovascular clinic, it's like a gold mine to find people with diabetes. If more than half have it, and if you consider the pre-diabetics, it's like that amount just grows.
Yes.
I don't even know what the number is, but it must be huge. And now with these inhibitors, if you have a patient with diabetes and heart failure, and you can reduce the cardiovascular risk by 30%, and it's independent of the amount of, the glucose reduction is really less than 10%, I think. I mean, less than 1 point in A1C. So,
yes.
So the guidelines were
they're very prescriptive on doing that, and they're very
So,
easy to, and the cardiovascular risk reduction and the heart failure hospitalization risk reduction is independent of their effect on A1C. So even if they are kind of average effect on A1C, there is still a big advantage in using them to reduce cardiovascular
And I
events.
think as cardiologists, we're going to just have to step up
Yes.
to the plate.
There was a paper which you mentioned, which kind of which encouraged the cardiologists that you guys should the cardiologists will have to go and prescribe these. But that is fine, because at PAMF, and Ed can tell you more about that we do involve all our specialty departments in quality of care. It's not just primary care. For example, our endocrinologists, they also do outreach on the patients that come within their care circle to make sure that their A1Cs are controlled and they're on their blood pressure medications, they're on a statin, etc. And cardiologists, we are partnering with cardiologists on statin use. So there is a lot of interconnectivity within the departments. It's not just primary care, definitely. So that's our one team, and then, as I said, our quality teams and population health teams are involved in development of databases and patient reports based on which we do strategic outreach to the patients to close the care gaps. And these outreach calls are linked to a PCP appointment or a diabetes or a diabetes educator appointment, depending on the risk on the risk, because the high risk patient, we also link them to diabetes education directly. We can ask them that, okay, hey, did you see a diabetes educator? Are you interested? The referral can be pended, which the physician can then sign. And there are dashboards which are maintained and which are then again linked to the clinics, because these can be drilled down to clinic level and physician level, the dashboards and our reports.
On your EHR, on your slide, it shows that the embedded decision-making, I assume that's a shared decision-making tools. Do you guys
Yes.
track that with your PCPs or internal medicine if they're using them? Or is it just available in Epic and if they want to utilize it or not? I know the AMGA, Together the Goal,
Yes.
uses Emmys in
Yes.
Solutions one, so
So
curious.
we, no, we haven't, they are available, but we haven't reached to a point where we are tracking them, but that's a conversation which is going on. Because one of the planks for Together to Goal is adoption of treatment algorithms. And so the treatment algorithms, the guidelines we have developed, but we still have to figure out a way to measure if these are being used.
Yeah.
So we are in the process of that conversation.
Yeah, kind of the shared decision-making where it's the patient with the provider, or if you're using your
Mhm.
educator, was curious if you're having success and where that conversation is starting.
The only data we are tracking is our diabetes education referrals right now. We don't have data for,
Our next story has a story about shared decision-making.
Yeah.
Ah.
with the million hearts definitely.
And I just had a question about the dashboard. So you're presenting these dashboards back to the physician and saying, hey, when you're seeing something not meeting your target number, what happens? Does the quality team develop a tool to address that to help out the primary care physician? Like, what's the outcome of those?
So it depends on what, so it depends on what we are looking at. Let's say if we look, and we also look at the variation, right? Let's say if we see, for example, is eye exam rates, okay? So right now in our clinic, we are working to improve our eye exam rates because there are several reasons why they could be low. So if we look at the rates that one physician has 80%, other is 75, 72, but then if one is, let's say, 40%, then there's something happening. So then we would look at that and see if the workflow that is being developed for the medical assistants, if that's not being followed, if they have a new medical assistant that has just joined and they just don't know that they have to update healthcare maintenance when the patient comes in, or is the physician not putting in the referrals? So we try to investigate that and see what solution, what is the root cause, and then try to come up with a solution. So, and this is done at each clinic level by, it could be the other associate medical directors who could, do it, or the T1s, but it is not meant to be punitive or not meant to be. It's more to finding a solution. Maybe the process is broken somewhere.
And just building on that question, do you give incentives to the teams to meet certain benchmarks?
I think Ed can probably answer that better because we do have incentives built in.
The incentive is at the population level,
Mhm.
not at the individual level yet. So you collectively, not to that granularity, another way I should say it, they do incentivize on hitting quality goals. We have not mapped it to the exact work for what each team member does. That has not happened yet.
So Bob Trine used to be at Gunderson Healthcare, one of the other top performing groups in the country. And Mike Dolan, their medical director, came out and talked about how they gave financial incentives to the teams to hit that blood pressure target. And not to an individual doctor, but are their group of patients at their 80% target for blood pressure control, and gave financial incentives. So it's just something to consider in your toolkit.
We've looked into that. That'd be a separate conversation for a future discussion on that. But yeah, we do recognize there is a role for financial incentives, and I think one has to be very strategic in how we use that, because we found there are a lot of unintended consequences with that.
Oh.
Yeah, that a conversation for a different time.
So our EHR supports this, our care of diabetes patients too. We have developed diabetes Smartsense, which the physicians can use to make the visit more smoother. We have embedded, we have the guidelines which are attached to those Smartsets, the patient handouts, like the Lantus handout or GLP handout or carb counting handouts. All these handouts are available which the physicians can give to the patients at the time of the visit. And also the referral to diabetes education and all is embedded within Epic. We have the ASCVD risk calculator, which is used in Epic, and I've been using that quite a bit when I'm talking to patients about statins, to show them their cardiovascular risk and.
Chhavi, how about just pacing, I don't know how much you want, a few more
I
minutes?
think that, I'll just this is again, when in the clinic what happens, I mean, the medical assistant has assigned roles that they have a sort of a rooming process that they go through, where they check everything, the physician does a lot of things as well, and referral to diabetes education. So what I'll just mention, one thing is that we do emphasize on frequency of contact for the high-risk patient, because the more the frequency of contact, better the A1C outcomes. So you have your visit with your primary care physician or endocrinologist, but you have those in-between visits with your extended care team, with your diabetes educator or your pharmacist. That does improve outcomes, and we want to follow that as much as we can. So again, just a team-based approach. We are working on clinical inertia as well right now, because clinical inertia is a huge
You want to
topic.
define what that is?
Okay, so clinical inertia is basically failure to intensify or accelerate the treatment per the treatment guidelines, and there could be a variety of reasons for it: patient-based, physician-based, system, insurance, cost, a lot of that. So our team is working on that right now. We are trying to identify what are the causes of clinical inertia, and as Ed had mentioned, a lot of it we are finding a lot of issues with patient motivation and engagement. So we want to explore more on resources for that and how we can engage our patients better. Development of resources for primary care physicians, guidelines or decision-making tools which are readily available to them, so that at the time of the visit, define the visit as diabetes visit, do the pre-work for the patient comes and sees you just for your diabetes, and then you can use those, an ideal world, right? You could use all those resources to help guide the patient and take care of the diabetes. And we are looking at a lot of Epic-based tools to see which could give us the data on medication adherence specifically, so that if that data is available to primary care physician at the time of the visit, they could potentially address that, provided that the patient doesn't come in with anxiety or 100 other things that they come in with. But that's what- yes.
Should we switch gears to the heart?
Sure.
The last 10 minutes.
So Ed, I think what we're gonna do is have you continue up to 6:15, and then we'll just do discussion in a round instead of doing the breakout groups, because it's really great content, and we don't want you to skip this important
Okay.
material.
Thank you. Thank you for your attention. I know it's hard just to sit because I think I brought enough content for 2 hours. In the interest of time, I'll narrow down to my next talk here to the shared decision-making story. So another initiative that we're participating is Meal and Hearts. So Meal and Hearts is a CMS program sponsored by CMMI. It's a Valley-based plan, and its goal is CMS' first experiment Valley-based paid for primary prevention, and the goals are on the screen over there. I'm going to skip this slide, you already know. So the purpose of this is really engaging the high-risk Medicare population about their cardiovascular risk. They use the risk calculator. Granted, there are pros and cons about that, but at least it's a straightforward and simplistic tool that even patients themselves can plug in the numbers and see where they are. Again, we look at it as a dialogue starter to engage patients on their journey about that. It's less about the number, it's more about how you aggregate all those factors together to see where you are. Let me go to this slide over here. We have a lot of these patients, right? And again, the story is about implementation here. 20,000 of these patients, and now in the program, don't have a heart attack about this, for those of you who read this. They define high risk as 30% or higher.
That is really high.
That's just the way how the program is. So based on that, the number of patients we have is in the thousands. So the question became is, how do we engage these patients on this journey to bring increased awareness so that while you're supplementing this with the care they get with their existing care, with their primary care teams. When we launched this program, that happened to coincide at a time where we have access challenge in primary care. So again, one of the customers, we have to do it is in a way how we can do this in a way that doesn't break the back of primary care. Because the grant required that the patient had a visit with a clinician.
Did you say there was a grant for this? Sorry. Do you need another bottle of water?
To the extent it's, the grant is the value-based pay program they're experimenting, so it's not upfront grant. It's, they call it a grant. It's basically experiment value-based pay. So if you hit the outcomes, you get value-based pay payment. That's what this is. Thank you. So we landed on is that, gosh, if there's any better way of doing population health, this is it. You have a defined cohort of, we know who the high-risk patients are. They all need to be educated on this. And also the interventions per this program are pretty straightforward. It's basically the typical things we do, the ABCSs, aspirin, blood pressure, cholesterol, stop smoking. So what we did is we deployed a shared medical decision-making, a shared medical appointment model. Because what we found over there is that, and I'll tell you a story. I ran that a few times, and then there's a patient I remember coming into this. Not my patient, one of our PAM patients. She has been diagnosed with hypertension for over a decade. When she came into the program, her blood pressure was not well controlled. I think, forgot what the number was. And we brought her in here for the discussion. And when we talked to her, she said, I never been told that I had high blood pressure. I never knew that I had that at all. Which was a light bulb on is that we are, on the clinician side, it's pretty easy. We plop it into the chart. But again, and I realize that sometimes where we miss is, do the patient understand that? So the beauty of a group visit is that because a lot of our patients that are in here are already on multiple medications, and polypharmacy, as we know, is a challenge as well. So some of the times the dialogue is at how might we engage a patient to improve their blood pressure, their lipids or whatever, in combination with lifestyle with that. And the power of that patient that visit is that she is with a cohort of other patients that have similar background and numbers that she has. And through a peer group setting that you are able to get from a group visit appointment, instead of the doctor telling her what to do, it's her peers giving her ideas about that. And then sometimes there are patients that do take multiple medicines and understand the value of that, and from them to engage a patient who may be reluctant to do so. That's where the magic happens. One of the grant process flows, these are tools that we develop to help the clinician to standardize documentation and capture some stuff. But what I want to go to is talk about shared decision making. Because that is one of the requirements for this program. Again, in the world we're in, and if you do observations, and I know any of you are going to observe doctors and not doctors' visits up there, sometimes doctors can't help themselves to tell patients what they should do. Okay. With all great intentions, because we are the clinical experts, and that's why they come to us. Again, I mentioned at PAMF, we have better opportunities to improve adherence to medications for chronic conditions. So I think one of the areas that we can do better is really be mindful of how we do shared decision making. You know, one of the things we want to tell them to do is that, remember, clinician, at the end of the day, it is the patient's choice. You know, I can in 1 minute prescribe aspirin, intensify the blood pressure medicine, start them on a statin, and be done with it. Here you go, see you back and get your blood test in 3 months. That's the easy thing to do, and in fact,